I lead a very talented team of software engineers who specialise in virtual reality and haptic engineering. What we do is we combine various elements, particularly including haptics or touch, in order to create immersive surgical experiences. As a team of engineers, we rely upon our global medical panel to ensure the authenticity of the surgical simulations that we're making. We work very closely with them, which can be incredibly inspiring and informs our direction of travel. The group met recently and had a wide-ranging discussion about the future of haptics and VR in surgical simulation. Here's some of the highlights of what they discussed.
So guys, what do you think research is important in terms of this technology?
Direction of travel is all accreditation, it's all validation, isn't it, and certification, and as that's rolling out across the world, not just UK, US and Europe, then demonstrating that and have the chance to demonstrate it in a more rigorous way has got to be more valuable.
But you've nothing to measure of it, Kadaba. If you've done the training, you've got nothing to measure of it. So you can't go back to your insurance, for example, and say, look, I'm doing this high-risk procedure. Actually, I'm okay to do it because when I do scoliosis, pedicle screw replacement, my accuracy is 90% plus.
Yes.
You haven't got that. You can't go back to your insurers. And I can imagine that the insurers actually, and your hospital might be quite interested in and if it comes to medical legal cases, if you can actually demonstrate that your team, everybody in your team, fulfills the minimum benchmark, that's going to go a long way. And also it's a nice reassurance to patients too.
I mean, this has essentially come from the flight simulator, hasn't it? And you don't go up in a real plane unless you've done 40 hours of flight simulator. Because that gets you to a certain level of competency and moves you on to the next level.
Well, especially
in live surgery, isn't it?
Yes,
So, yeah.
And you can't train people on the complication. You cannot, create the complication. You can't. So the only way to do the complication is simulate it.
Bird strikes. That's where bird strikes come from.
Yes,
Right.
absolutely.
And the margin there for live patients is so small, you can sort of train on this over and over and over again.
Yeah.
Get the angles right, measure what you need to measure.
Yeah.
In the operative theatre, you're much more efficient. And for older surgeons, you can track yourself over time, because there's a data out there that older surgeons with much experience may not actually be better, because they may not keep up with the latest techniques, they may not be current, their skills may erode, they may not even realize it. It's difficult to challenge older surgeons who have experience and standing in a hospital setting. The way to follow that is benchmarking with yourself over time.
Yes.
And we mentioned that earlier. That's a very valuable asset to have.
I think it's been interesting in our discussions actually about the range of possibilities and probabilities here of what you can do with this, effectively a tool that's going to allow us to help very novice doctors in very basic procedures up to experts doing complex work, and how you can both train and assess and feedback and monitor across the whole range of things. I think that's a really interesting conceptually, and I don't think it's really been done before. It's little bits have been nibbled at, but I don't think anyone has done this in a comprehensive way that would be recognisable by authorities, if you like, be it insurers or be it regulatory or be it professional bodies.
One area of development has been the combination of immersive virtual reality with haptic feedback. This is unique technology being created by fundamental surgery, and here are the group discussing why it's so valuable in practice.
I think it's hugely valuable because that is something you simply cannot learn from a textbook, from instruction. You have to develop that feel. And in a procedure, if you're doing a scoliosis procedure, your trainee may be able to do one side, so you'll put in, say, 6 straight screws. That's the end of the learning experience. Yet developing that tactile feel, or how this feels, is such an important key step of the procedure. And this way, you can just do it 2, 3, 4, 5, 20 times until you have that feel right. Which during surgical training is going to take vastly longer to develop that tactile feedback and that muscle memory.
So the haptic application, can you actually feel the screws that enters the bone?
Well,
And would you be able to feel when you're outside the bone? Right?
Yeah, totally.
So what do you mean haptic?
So there's a specific feel of the device. We use a blunt device to go down the pedicle. So the pedicle probe is a blunt device. And there's a specific feel that you get with this device, the blunt probe, which you gentle pressure force down the pedicle. There's a very specific feel to it as it goes through cancellous bone versus a hitting cortical bone.
Yes. So Omar, you've developed the posterior hip approach. How valuable is the haptic asset in terms of training when you're reading an acetabulum or you're pounding in a cup?
Extremely valuable. We've done quite a lot of work on trying to get the visual aspects in addition to the haptic aspects working together. So for example, on a reamer, you can see the travel of the reamer as you progress with your motion, but also there is vibration in your hand, and as you get to the end of what the tool's supposed to do, then the whole thing goes loose. So the haptic aspect actually replicates what happens intraoptically. And I don't think there's any other tool out there that will give you that same combination of visual and haptic together.
So in terms of education, do you think that's an important asset as far as training residents?
Absolutely.
In terms of surgery?
Absolutely. I teach on quite a lot of primary hip arthroplasty courses, and that's the main criticism, the whole feedback that we get from all the courses is, I've only done one of these operations because obviously I'm not trained well enough to do it. How can I go and learn the operation? At the moment there is no other means by which they can do that.
This section is particularly interesting. The panel explore the need for objectivity and measurement of the training effect. They also reveal opportunities to unlock potential at the psychological level.
I think so. People talk about clinical outcomes versus computer-generated or simulator-generated outcomes. You can almost think of them in terms of conscious and subconscious outcomes. So if you're looking at, if we stick to the orthopedic models, screw depth, screw angle, those are very objective, right or wrong, how close to ideal are your results. And then you've got all these other metrics that you really only can get from the computational power of a simulator, where you're looking at things like we talked about, travel time, tremor, time through operation, and all these things that are fairly standard, are very, very well validated in general surgery, ophthalmology, urology, to name a few. And while I'm not entirely sure whether they're fully validated in orthopedics, the fact that they're done at least in 3 or 4 other specialties, there's no reason why they shouldn't be. And so you've got that conscious feedback, what have you done well, what not well. You've got that subconscious feedback, which will show you your more graduated learning curve in terms of going from novice to expert. And then if we build in something like, so the video capture showing you and replaying you those errors, that almost builds in actually an element of surgical coaching as well, which really is one of these really, really hot topics at the moment, where people are looking at, well, how do we actually teach? It's not just repetition. How can we optimize teaching? And in everything else, of course, from aviation to elite sport to anything, the way you get better is coaching. People tell you what you've done wrong, what you've done right, and you replicate and repeat those steps that you need to improve on. And this is the kind of thing that you're talking about isolating those key steps. And if we're able to replay those errors and allow people to self-reflect on those and feed back to them on their performance, that's a really powerful tool in my mind.
So we do know that when a surgeon looks away from the operative field, that decreases his efficiency, and surgeons do that far, far more than they realize. So a study looked exactly at that, and they found the most efficient surgeons do not remove their gaze from what they're operating on. And that requires, of course, that your surgical techs do the right instruments. It requires the proper communication, but you don't want a surgeon communicating with others in the room other than individuals directly responsible for that surgery. So you can build that into the system where you watch a person's gaze, how often they look up, where they're really looking, and map that over time as to whether their surgical efficiency and accuracy increases. So that's one way of doing it. You can also watch the movement. It's like in Formula One racing. They have it down to a science, refilling the fuel, changing tires. We can do the same thing with surgery by adapting this system to monitor those over time. It'd be a phenomenal asset to do that.
I think that's really interesting, because it's not one of the things we get taught as a surgeon growing up, is how to improve your efficiency. You learn it as you grow up just by your inherent ability to realize what is efficient and what isn't. But nobody actually ever tells you growing up, by the way, keep your gaze entirely on the point of focus. Don't
That's
look
correct.
outside.
It's never taught. And
It's
we
never
know
taught.
some surgeons are very fast, very efficient, have a low complication rate. We don't really know why. We say they're better, but why are they better? And I think it's something we can teach everyone with the right tools. And I think this approach, VR, the haptic application, is one way of doing that.
One of the fundamental of VR's headline statements is about democratisation of surgical education, and perhaps opportunity could be tucked onto the end of that. And there's quite a lot of evidence that there are more and more women coming into surgery, but they're still a small minority, relatively speaking. And one of the reasons that is often put forward for that, for why women come into surgery and then don't proceed up to consultant level and senior level, is about confidence, about putting themselves forward. Mm-hmm. Now, we've got a tool here which might be able to allow you to demonstrate in the privacy of your own module that you are at least as good as your peers of whatever gender, race, creed, or whatever else as everyone else. And maybe there is a little bit of democracy in that. So you can actually demonstrate your ability in a completely unbiased and rigorous way.
In the last section, the panel discussed the development of surgical simulators in relation to the development and evolution of flight simulators for pilots.
It's amazing how it's taken that long, especially that with the aviation industry, it's driven by safety.
Yeah.
Error is unacceptable, or it should be exactly the same as surgery.
It should be
It should be the same as
It should
surgery.
be the same. Error is not acceptable, or at least
It's not acceptable.
it should be a very, very tiny margin of error. But yet for years we've just carried on and said, oh, there is an element of human error. We just have to accept it.
You wouldn't get into a plane where you know that the guy is going to fly it, and right, perhaps if we sat next to him, this is his first go at it. You're like, no, I'm going to try landing this. You say, well, no, I'm not getting in that plane. Yet in surgery, we expect patients to accept that. This is the first time it's good. You don't even tell people.